The prostate remedy. Big Pharma doesn't want men over 50 to know about. Let me start with something that might sound surprising coming from a physician. The most effective interventions for prostate health in men over 50 are not pharmaceutical. They are not surgical. They are not particularly expensive. They are a specific combination of dietary compounds, daily movement patterns, and behavioral practices that address the biological drivers of prostate disease at a level that most medications do not reach. I am not saying this to be provocative. I am saying it because the evidence supports it, and because the men sitting in my waiting room deserve to know it. The reason most men over 50 have never heard a clear, complete, evidence-grounded explanation of these interventions is not that the research does not exist. The research absolutely exists. It is peer-reviewed, published in major medical journals, and increasingly informing clinical thinking among urologists who engage deeply with the literature. The reason is structural and economic. The medical system profits most from the management of established disease, not from its prevention. A pharmaceutical company spending hundreds of millions developing a drug has a powerful financial incentive to ensure that drug is positioned as the primary response to symptoms. A dietary compound that cannot be patented, a movement practice that requires no prescription, a behavioral habit that costs nothing. These have no equivalent marketing infrastructure. Nobody is funding the advertisements, the physician education programs, or the clinical guidelines development that would position them as first-line interventions. That is not a conspiracy. That is an economic reality. And understanding it is the beginning of taking genuine responsibility for your own prostate health. I am Dr. John Carter, and today I want to share the evidence-based approaches most often overlooked in the standard clinical encounter, the interventions that address the actual biological drivers of prostate disease rather than simply managing its symptoms. The two biological processes driving prostate disease, BPH and elevated prostate cancer risk, share two primary biological drivers that are underemphasized in standard clinical communication. The first is chronic prostatic inflammation. The prostate gland in a man with BPH is not simply mechanically enlarged. It is inflamed. Histological studies examining prostate tissue from men with BPH find inflammatory cell infiltrates in the majority of specimens. These cells release cytokines and growth factors, including interleukin-6, interleukin-8, and tumor necrosis factor alpha, that create a prostatic microenvironment that is simultaneously pro-inflammatory and pro-proliferative. A landmark study in the Journal of Urology found that men with histological evidence of prostatic inflammation had significantly larger prostates and more severe urinary symptoms than men without inflammation, independent of their hormonal profile. Elevated serum inflammatory markers were among the strongest predictors of BPH progression over time. The second driver is insulin resistance and elevated IGF-1. Chronically elevated insulin, the consequence of diets high in refined carbohydrates consumed repeatedly over years, stimulates the liver to produce excess insulin-like growth factor 1. IGF-1 is one of the most potent and specific drivers of prostatic cell proliferation known to science. Multiple large prospective studies have established that men in the highest quartile of serum IGF-1 have a risk of advanced prostate cancer 4 to 5 times higher than those in the lowest quartile. Studies examining BPH specifically find that men with insulin resistance have significantly larger prostates and more severe urinary symptoms than insulin-sensitive men of the same age. These two drivers, chronic prostatic inflammation and insulin resistance with elevated IGF-1, are both significantly and measurably addressed by the interventions I am going to describe, not peripherally, directly, through documented biological mechanisms. The first overlooked intervention, specific dietary compounds with documented prostate protective activity. Lycopene has the most robust and consistent evidence base of any dietary compound for prostate-specific protection. It accumulates in prostate tissue at higher concentrations than any other tissue in the body. A meta-analysis of 21 prospective cohort studies found that higher lycopene intake was associated with a 25% reduction in prostate cancer risk. The Harvard School of Public Health found that men consuming tomato products 10 or more times per week had a 45% lower risk of prostate cancer compared to men consuming fewer than 1.5 servings per week. Lycopene directly inhibits cell cycle progression in prostatic epithelial cells, reduces IGF-1-mediated signaling in prostate cells, and is a potent antioxidant protecting prostatic DNA from oxidative damage. Critically, lycopene bioavailability from tomatoes is dramatically enhanced by heat processing. 4 ounces of low-sodium tomato juice consumed with a small amount of fat is one of the most efficient lycopene delivery vehicles available. Green tea and its active compound EGCG represent the second major evidence-supported dietary intervention. EGCG inhibits 5-alpha reductase, the enzyme converting testosterone to dihydrotestosterone within prostate cells. This is the same enzyme targeted by pharmaceutical 5-alpha reductase inhibitors, like finasteride. EGCG also inhibits androgen receptor signaling in prostatic cells and directly blocks the nuclear factor kappa B inflammatory pathway. A randomized controlled trial published in Cancer Prevention Research found that men with precancerous prostate tissue who took green tea catechins had significantly lower progression rates after 1 year compared to placebo. Human clinical evidence for a beverage available in every grocery store for less than the cost of daily medication. To maximize EGCG content, brew green tea at 70 to 80 degrees Celsius, not boiling. Steep for 2 to 3 minutes. Do not add milk because casein proteins bind to catechins and dramatically reduce their bioavailability. Curcumin from turmeric inhibits nuclear factor kappa B, reducing the pro-inflammatory cytokines directly driving prostatic inflammatory infiltration. The critical limitation is bioavailability. Less than 1% of orally consumed curcumin reaches systemic circulation without absorption enhancers. Adding piperine from black pepper increases curcumin bioavailability by up to 2,000%. A 1/4 teaspoon of turmeric with a pinch of black pepper in warm water with a small amount of olive oil produces a delivery system with meaningful curcumin concentrations reaching prostatic tissue. Zinc is concentrated in the prostate at higher levels than virtually any other tissue. It regulates 5-alpha reductase activity and supports the anti-inflammatory function of prostatic epithelial cells. After 50, dietary zinc absorption typically declines. Raw pumpkin seeds, approximately 30 grams daily, are the most bioavailable dietary source. The morning routine delivering these compounds consistently. 4 ounces of low-sodium tomato juice with a pinch of black pepper and a 1/4 teaspoon of olive oil, 1 to 2 cups of properly brewed green tea without milk, a 1/4 teaspoon of turmeric with black pepper and olive oil in warm water, a handful of raw pumpkin seeds. These 4 preparations deliver the most evidence-supported dietary compounds for prostate protection efficiently and practically. The second overlooked intervention, the movement practice addressing 3 biological drivers simultaneously. The health professionals' follow-up study, following nearly 30,000 men for over a decade, found that men engaging in vigorous physical activity for 3 or more hours per week had a 35% lower risk of developing symptomatic BPH requiring treatment compared to sedentary men. A 12-week randomized controlled trial in the Journal of Urology found that a structured exercise program produced international prostate symptom score improvements comparable in magnitude to alpha blocker medications, without any pharmacological intervention. Physical movement addresses prostate disease through 3 mechanisms that medications target separately, if at all. The first is skeletal muscle insulin sensitivity. Physical movement is the single most powerful intervention for improving skeletal muscle insulin sensitivity available without medication. A single session of moderate activity improves insulin sensitivity for 24 to 48 hours. Daily movement maintains this improvement continuously, preventing the insulin resistance that elevates IGF-1 and drives prostatic cell proliferation. Post-meal walking specifically targets the postprandial glucose and insulin surge. Walking within 15 minutes of finishing a meal activates lower body muscle glucose uptake at exactly the time when blood glucose is rising toward its peak. Research in diabetes care demonstrated that 3 15-minute post-meal walks produced superior blood glucose control compared to a single 45-minute walk at another time. The second is myokine release and systemic inflammation reduction. Skeletal muscle releases interleukin-10 when it contracts, a potent anti-inflammatory cytokine directly counterbalancing the pro-inflammatory cytokines driving prostatic inflammation. Regular physical activity significantly increases chronic baseline interleukin-10 levels, reducing the inflammatory infiltration of prostatic tissue. The third is pelvic blood flow restoration. When prostate tissue experiences inadequate oxygen delivery from prolonged sedentary behavior, it activates the HIF-1 alpha growth-promoting pathway. Research using Doppler ultrasound found that 30 minutes of moderate walking produced a 45% increase in pelvic arterial perfusion persisting for 2 to 3 hours afterward. The movement prescription: post-meal walks within 15 minutes of finishing lunch and dinner. Every 90 minutes of sitting, stand and perform 20 heel raises. 3 times per week, 30 minutes of lower body weight resistance exercise, squats, lunges, and hip hinges, 3 sets each. This prescription addresses all 3 biological mechanisms simultaneously. It requires no equipment, no gym membership, and no expense. The third overlooked intervention: the nightly fluid management protocol, resolving most of the nighttime urinary frequency driving men to seek treatment. I want to present this here in the context of why it is so rarely discussed in clinical settings. Because it produces the same kind of symptom improvement that alpha blocker medications produce, but through a behavioral mechanism that requires no prescription and generates no pharmaceutical revenue. The mechanism: throughout the day, fluid accumulates in the lower leg tissue under the influence of gravity and declining venous valve function. By evening, up to a liter or more may have pooled invisibly. When you lie down, this fluid reabsorbs into the circulation, triggers atrial natriuretic peptide release, and your kidneys process it at 2 in the morning. The leg elevation protocol interrupts this cycle. 60 minutes before bed, legs elevated above heart level for 25 to 30 minutes, with ankle exercises and diaphragmatic breathing to accelerate fluid return, followed by a voluntary void of the mobilized fluid before lying down to sleep. This single intervention reduces nighttime voiding frequency by 1 to 3 episodes in most men within the first week, without medication, without a prescription, through the simple physics of gravity applied deliberately. The post-dinner walk taken within 15 minutes of finishing the evening meal further reduces the reservoir that accumulates by activating the musculovenous pump of the lower legs before the evening sitting period allows significant accumulation. The fourth overlooked intervention: managing the hormonal environment through specific behavioral practices. Pharmaceutical management of BPH addresses 2 hormonal mechanisms. Alpha blockers reduce sympathetic smooth muscle tone. 5-alpha reductase inhibitors reduce DHT production. Both are effective for the mechanisms they target. What they do not address are the hormonal disruptions produced by alcohol consumption, sleep deprivation, and chronic psychological stress. Alcohol elevates the estrogenic environment of the prostate through impaired hepatic estrogen clearance and increased aromatase activity. Regular evening alcohol consumption produces a chronically elevated estrogen to testosterone ratio in prostatic tissue that directly promotes epithelial cell proliferation through a mechanism that neither alpha blockers nor 5-alpha reductase inhibitors address. Sleep deprivation reduces overnight testosterone production, elevates chronic cortisol, increases insulin resistance and IGF-1 elevation, and maintains the sympathetic tone that adds urethral resistance. A study examining over 5,000 men found that those sleeping 5 or fewer hours per night had significantly higher international prostate symptom scores than those sleeping 7 to 8 hours after controlling for age, BMI, and other confounders. Chronic psychological stress elevates cortisol, which suppresses testosterone production, elevates blood glucose, and maintains the sympathetic nervous system activation, adding to urethral resistance and prostatic smooth muscle tension. The behavioral practices addressing these hormonal mechanisms are elimination of evening alcohol, consistent sleep timing, and adequate duration, daily diaphragmatic breathing to reduce chronic cortisol and sympathetic tone, and regular physical exercise, which is the most reliable cortisol-reducing behavioral intervention available. The fifth overlooked intervention. The pelvic floor practices improving urinary function without any change in prostate size. The chronic pelvic floor tension that almost every man with BPH carries is almost never identified in a standard clinical encounter. The pelvic floor in a man with BPH is frequently in a state of chronic tension from the sustained daily effort of initiating and maintaining urinary flow against a narrowed urethra. That tension elevates intraprostatic pressure, impairs local prostatic blood circulation, maintains sympathetic activation, and prevents the bladder from reaching its full functional capacity. Morning pelvic floor activation. 15 repetitions of correctly performed contractions engaging only the internal pelvic floor muscles, held for 5 seconds with a complete 5-second release. The release is as important as the contraction because it directly addresses the chronic tension. Evening pelvic floor release before sleep. 15 slow breathing cycles in which each exhalation is paired with a deliberate dropping and softening of the pelvic floor. This releases the tension accumulated through the day. Research consistently demonstrates that structured pelvic floor exercise programs improve international prostate symptom scores, urinary flow rates, and post-void residual volumes in men with BPH independently of any change in prostate size. Why these interventions are not in the standard clinical conversation. The interventions I have described are not experimental. They are evidence-based practices supported by peer-reviewed research in mainstream medical journals. They are absent from most clinical conversations for 3 interconnected reasons. Time. A 15-minute appointment structured around selecting the appropriate pharmacological response has no space for a comprehensive discussion of the dietary, movement, sleep, and behavioral factors contributing to the presenting complaint. Incentive structure. Pharmaceutical companies fund the educational programs, the clinical guidelines development, and the continuing medical education through which most physicians update their clinical practice. These programs present pharmaceutical interventions comprehensively and behavioral interventions incompletely through the natural consequence of where the funding flows. Patentability. A dietary compound that cannot be patented, a movement practice requiring no equipment, a sleep habit costing nothing. These generate no commercial return, justifying the investment required to establish them as primary clinical recommendations through standard channels. Your complete implementation plan. Every morning before getting out of bed, 30 ankle pumps lying flat, 15 pelvic floor contractions with full 5-second releases. 10 minutes of diaphragmatic breathing, morning preparations, water with lemon immediately upon waking, low-sodium tomato juice with black pepper and olive oil, properly brewed green tea without milk, turmeric with black pepper and olive oil in warm water, a handful of raw pumpkin seeds. Through the day, consume 60 to 70% of total fluid intake before 2 in the afternoon. Set a recurring 90-minute alarm. Stand and perform 20 heel raises when it activates. Walk 15 minutes within 15 minutes of finishing lunch, 3 times per week. 30 minutes of lower body weight resistance exercise. Squats, lunges, and hip hinges, 3 sets each. At dinner, low-sodium whole food preparation, protein consumed first, no refined carbohydrates, no alcohol. Walk 15 minutes within 15 minutes of finishing the meal, 60 minutes before bed. Legs elevated above heart level for 25 minutes with ankle exercises and diaphragmatic breathing. Void 30 to 40 minutes after completing the elevation. Before sleep. 15 breathing cycles with deliberate pelvic floor release on each exhalation. No screens for 30 minutes. Consistent sleep time. This protocol addresses every primary biological driver of prostate disease through mechanisms that are understood, documented, and measurable. It costs almost nothing, it requires no prescription, and it produces results that compound over weeks and months in ways that pharmaceutical symptom management does not. The medical reminders. Annual PSA testing and prostate examination after 50 are non-negotiable and not replaced by any behavioral protocol. They identify the minority of men whose prostate growth has a malignant cause requiring entirely different management. If your symptoms are severe, if you are waking 3 or more times per night, if your flow is significantly compromised, medical evaluation and appropriate pharmacological or procedural management is appropriate alongside these behavioral interventions, not instead of them. Sudden inability to urinate is a urological emergency. Blood in the urine requires prompt evaluation. Rapidly worsening symptoms warrant investigation. The purpose of this conversation is not to position behavioral interventions against pharmaceutical ones. Both have roles. The purpose is to ensure you have access to the full picture, including the parts that the standard clinical appointment most often leaves out. Because a man who understands both the pharmaceutical options and the behavioral interventions that address the underlying biological drivers makes fundamentally better decisions about his prostate health than a man who only knows about the pills. That understanding has always been what you deserved. This is Dr. John Carter. Take care of your prostate with everything the evidence has to offer. I will see you in the next one.